Step 1 respiratory case vignettes will often discuss lung physical exam findings that will help you clue into the diagnosis. Remember that resonance refers to the sound you hear when you percuss the chest, and fremitus is the palpable vibration with low frequency vocalization. So if you have an area of decreased breath sounds, resonance and fremitus with tracheal deviation towards that affected side, you might think bronchial obstruction. The tracheal deviation occurs because you get lung collapse distal to that obstruction. Now, if you hear decreased breath sounds with dullness of percussion, you may think pleural effusion. We'll talk more about pleural effusion later on in this section on page 574 if you want to peek ahead. If you have increased tactile fremitus, you should be suspicious of pneumonia or some other consolidating process. We'll talk more about tension pneumothorax on page 574, but this is one of those few respiratory emergencies where you often have to treat before the patient gets to the emergency room, much less get a chest x-ray. When too much air gets trapped, it pushes the mediastinal structures to one side, like the trachea here in this image. You can also get the classic triad of absent breath sounds, hyperresonance, and decreased fremitus. You'll also see the same things with a spontaneous pneumothorax, except that if there is any tracheal deviation, it would be towards the side of the lesion. Lung cancer remains the leading cause of cancer death among both men and women. Suffice it to say, this topic is very high yield for step 1, and you're going to want to put a big star by it. Lung cancer may clinically present with cough, hemoptysis, and so forth, or it may show up as an incidental radiologic finding. Metastasis to the lung is the most common malignancy you'll find in the lung. Mets are typically coming from primary tumors in the breast, colon, prostate, and bladder. On the other hand, when primary lung cancer metastasizes, it frequently goes to the adrenals, the brain, the bone, and the liver. The complications and sequelae of lung cancer are pretty high yield, and the sphere mnemonic does a pretty good job of summarizing the big ones. Other than these conditions causing their own set of problems, why is it important to know these complications? It's important because they're often the first signs and symptoms of lung cancer, and we'll talk about them on the next page. Let's dive into the different cancer types. As we go through the various lung cancers, keep in mind their typical position in the lung, whether or not they're associated with smoking, their associated symptoms, and histologic characteristics. Small cell or oat cell carcinoma is a centrally occurring lung cancer. This type of cancer is extremely aggressive and poorly differentiated. It can produce excess ACTH or ADH, causing one of the classic perineoplastic syndromes. Think for a moment how this might clinically present on the boards. With excess ACTH, you may have excessive cortisol release and a Cushing-type syndrome, while with excess ADH in the absence of normal stimuli, also known as the syndrome of inappropriate ADH, can lead to fluid retention and hyponatremia. You can also get autoantibodies against neuromuscular junction calcium channels, causing Lambert-Eaton syndrome, where patients classically present with what? That's correct, proximal muscle weakness. On histology, you can see the chaotic or undifferentiated quality of this lung cancer. And over here we have another example. The small dark blue stained cells are neuroendocrine Kolchitzy cells, which can lead to some of the perineoplastic syndromes we just discussed. This type of cancer is not resectable. Why is that? It's because metastasis often occurs very early on. It can be treated with chemotherapy, but unfortunately has the worst 5-year prognosis among the major cancer subtypes. Adenocarcinoma makes up about 1/2 of all primary lung cancers, so it's the most common one out there. The bronchial subtype is more common in non-smokers and females. It usually occurs in the peripheral lung parenchyma, often at sites of prior injury or scarring. The bronchoalveolar subtype is also thought not to be related to smoking, and it typically spreads along the alveolar walls. On histology, you'll notice the involvement of Clara cells, or type 2 pneumocytes on histology. This form of lung cancer can also be surgically resected if you catch it early enough. Squamous cell carcinoma has clearly been linked to smoking, and typically presents as a centrally located hilar mass arising from the bronchus. So therefore you get the mnemonic squamous central smoking. With this cancer subtype, you can see the production of parathyroid hormone-related peptide. And what does this lead to? Well, it leads to hypercalcemia of malignancy. Of course, you probably recall from the endocrine chapter how parathyroid hormone stimulates osteoclast activity, thus releasing calcium from bone. Histologically, you see keratin pearls, here, here, and here, and intracellular bridges that are characteristic of squamous cell carcinoma. This cancer can also be resected if it has not yet metastasized. The 5-year prognosis is not great, but it will be better than small cell carcinoma. Large cell carcinoma tends to be peripherally located. This type of lung cancer has a very poor prognosis compared with the other non-small cell lung cancers. It's not really responsive to chemotherapy, and resection works only about half the time. On histology, what do you see? Shocker, you're going to see these large, pleomorphic, undifferentiated cells. Thus, of course, the name large cell. Carcinoid tumor is an interesting but uncommon lung cancer that carries a fairly good prognosis, which makes it perfect for testing on the step 1. How will you typically see this condition present? Well, in contrast to the more famous and classic carcinoid syndrome, carcinoid tumor typically presents as a bronchial obstruction with coughing or hemoptysis. If you were to biopsy the mass, histologically, you might see carcinoid cells in the classic rosette patterns, here and here. As I mentioned, you can occasionally see it present as carcinoid syndrome, where you get flushing, diarrhea, wheezing, and salivation due to the tumor's production of what? Correct, serotonin. You can also get fibrosis of the tricuspid and pulmonary valves from the high levels of serotonin, which can lead to right heart failure. So here's a board-related question. If you have someone who presents with carcinoid syndrome, where else would you look other than the lung? Well, carcinoid tumor more commonly presents in the small bowel and appendix. However, you usually don't see the carcinoid syndrome itself unless they are metastatic to the liver. And why is that? Well, that's because the substances released by the carcinoid tumor in those locations are typically metabolized and inactivated by the liver. Well, getting back to the lung, the good news is that this type of tumor tends to be slow-growing and does not metastasize frequently. This is mainly treated by surgical resection, and the 5-year survival rate is really good, 75 to 95% when compared with the other lung cancers. Finally, mesothelioma is a disease of the pleura, although it has also been diagnosed as a disease of the peritoneum. As we discussed earlier, this highly malignant disease is a result of exposure to asbestos, which, when you inhale it, can cause the development of those calcified pleural plaques. But in addition to asbestosis, you also need to know that the risk is multiplied with cigarette smoking. This condition is characterized by pleural thickening and effusion and has a high mortality rate. On cytology, you'll see these characteristic 3D clusters of at least 10 cells with knobby borders. On histology, you'll see psammoma bodies. These happen to be examples of psammoma bodies from a meningioma. As you can recall from the pathology section on page 255, these are laminate concentric calcified spheros that can be found in a number of cancer conditions. Pancoast tumor is a classic type of lung cancer situated in the apex of the lung. These are typically non-small cell cancers. Why is that? As you might remember, small cell lung cancer tends to be centrally located, not peripherally. You can get Horner syndrome through compression what? The cervical sympathetic plexus. You can also get pain and weakness in the arm and hand if what else is affected? The brachial plexus. And then finally, you can also get hoarseness. The right recurrent laryngeal nerve is involved.